Yeah. And just in case there's someone listening who hasn't heard of PNN ablation, can you just, talk about what that is? Because I mean, we didn't do PNN ablations when I was in training.
Yeah.
So it is possible that there are people out there, if you've been in private practice for a while, who may not have heard of this kind of technique.
Yeah, absolutely. Absolutely. So what the posterior nasal nerve is, it's the nerves that carry the parasympathetic supply to the nasal mucosa. Right. I'm going to bring us back to medical school for a little bit. Right.
Let's go. Let's go back.
Yeah, exactly. Right. Back to the good old days. Right. So how parasympathetic supply ends up in the nose, it actually goes along the cranial nerve 7, right, next to the ear. It then jumps off through a nerve called a greater superficial petrosal nerve. Right. And then that goes towards the nose. It actually joins in with another nerve called the deep petrosal nerve from the internal carotid artery. That deep petrosal nerve carries the sympathetic nerves, right? So both the parasympathetic and sympathetic join together, and that forms the vidian nerve, otherwise known as a nerve of the pterygoid canal, right? So there's actually a procedure that I used to do, or actually still occasionally do, where I go in and cut the vidian nerve, right? And so that it completely stops that parasympathetic supply to the nose, really helps stops a lot of that drainage and discharge and that swelling that's being triggered by the autonomic nervous system, right? The big downside of that procedure is about 20 to 25% of patients will now get dry eyes, serophthalmos, right? Because that same nerve that carries the autonomic nervous supply to the nose also carries it to the lacrimal gland. And so someone really, really smart, much smarter than me, back in like the early 2000s, discovered that this nerve, once it goes into the pterygopalatine fossa, that's where it connects with the postganglionic fibers, right? And so by then, the lacrimal nerves now shoot off from there. And then the rest of the nerves then go back into the nose, and those are called the posterior nasal nerves, right? And so we find that in the lateral portion of the posterior nasal cavity. And then those nerves are primarily now postganglionic parasympathetic supply just to the nasal mucosa. So by ablating that, by addressing those or lysing them, now you're able to dry out the nose, reduce the swelling without any effect to the lacrimal gland.
There you have it.
I know. A lot of anatomy. Yeah. But that's all what surgery's all about,
that was
right?
Great. That was great. Hopefully people that got out their old, anatomy books kind of,
old netter.
Followed it through.
Are these drawings in netter? I don't recall them, but
I still remember that moment in medical school, right? When I was going into ENT and realizing that netter wasn't enough. Right? Because once you start studying the ENT, right, the never diagrams are just a little bit too broad. It doesn't specifically, it's not detailed enough for ENT. So yeah, that was a big wake up moment. But there's been actually a lot of advances in our understanding of that nerve, even ever since then. Because back then, I think they just showed a couple of the nerves along that lateral surface. But as people have gotten more interested in this nasal nerve ablation or lysis, right, what they've done more anatomical dissections. And what they found is that rather than just a single nerve, it's a whole there's a whole group of them. Right? And those nerves would come out pretty much in a pretty random distribution in that lateral wall. Right, it comes out in the middle meatus, comes along that lateral surface. Some come out from the inferior meatus as well, right? And so, although that video neurectomy was a very clean surgery, right? It was very nice. It was effective, but it had a lot of downsides. When it comes to this posterior nasal nerve, it's a lot more of a distribution of nerves, right? So it's not quite as clean. So that's why I think it's so important to make sure you try to hit that area as much as you can in the hopes of hitting one of those nerves.
So how do you decide when you see a patient who's ready for this? Do you have them try, is there a certain amount of time you want them on the nasal steroid spray, or is ipratropium part of your repertoire, or who do you recommend it to? And what do you want them, how do you know you've maximized medical options?
Yeah, exactly. That's a great question. Right. And that is definitely the key question when it ever coming to counseling any patient about a procedure, right? Try to figure out when is it the right time to elevate them to that next level. And so if a patient has seen me and they're completely medication naive, I do usually put them on some medications first, right? And I kind of tell them what our evidence shows, that using these consistently is better than sporadically. Right, the BID dosing tends to be superior than just a single day, once a day dosing. And as far as time frame, I don't think we have much knowledge or much evidence of when is sufficient amount of time right? But I think most of us will at least try it for consistently for at least a month, right? That's what I consider a good solid medication trial. I don't have any good evidence for why a month, right? But that's just time frame in my mind that makes sense. I do primarily put people on like intranasal steroids, intranasal antihistamines, especially if they have an allergic rhinitis component. The ipratropium bromide, that is anticholinergic, right? So theoretically, what it's supposed to do is go back and suppress those nerves that is causing that parasympathetic overdrive. Now, I do try it on every patient. When they respond to it, I tend to be a little bit more hopeful that they're going to respond to the procedure, right? Because that, in my mind, makes sense. So if it's calming down the nerves by ablating those nerves, then obviously it's going to have that same effect as the ipratropium bromide. However, it's not a rule out medication for me. So if they don't respond, that might mean a couple of things, right? It might be that the nerves are too far in, that the nose sprays aren't reaching there, right? Or it might mean that they might have a different kind of mechanism that's going on inside the nose. So I still have, even if in patients who use the ipratropium bromide and don't feel like if they respond, I still have some of those patients respond to the nasal nerve ablation. But I think in general, I first try the medical therapy first, right? And see if they have sufficient relief. And then from there, that's where the conversation turns into much more of a shared decision making, right? Because what I want to do is now sit down with the patient and try to understand how much is this really impacting their quality of life, right? I think in general, if the patient feels like it's kind of a nuisance but not bothering them too much, then I usually don't offer any procedural intervention, right? Just because I want to make sure if I'm doing a procedure that we're maximizing the possibility that they're getting some kind of gain from it, right? But if it is still causing them significant impact on their quality of life, where it's causing them that social embarrassment or impeding them from exercising, or sleeping, doing their daily activities, and that's usually when I have the conversation to see whether they want to try this procedure.